Yeah, so welcome to this webinar on joint webinar on myopia prevention of onset and retardation of progression guidelines, which we had formulated over 1.5 years. And today we are launching the hard copy of these guidelines. We hope that these will be distributed all over the country by the extensive network of the entered pharmaceuticals. And as we all know, myopia is a very difficult disease condition. There are so many aspects of it. We understand very little about it, at least at the cellular and molecular level. So there are a lot of things which have to be connected. So till that happens, we will have to bank upon the guidelines to manage these conditions. And as we know, it's a sort of an epidemic, which is a global epidemic, and about 50% of global population is supposed to get myopic by about 2050. So we need to have a preventive as well as therapeutic modalities in place, and we need to create awareness to the community also, and so that we are able to handle it in time. Otherwise, it will have a lot of economic, financial, and quality of life issues for the entire world. And as we know, in South Asia, particularly if you look at China and Japan, these countries are having almost 90%, 85 to 90% of myopia in younger children, and we are just next door neighbors. So it is a very essential part that we devise right strategies and act in time, and rather wait and then get into trouble. So today we have a very distinguished panel of speakers and panelists who have a lot of experience in pediatric ophthalmology and in myopia management and diagnosis. And before we move on, I will request Dr. P. Deshpande, our worthy president, to say a few words on this topic. Dr. Deshpande.
Sir, unmute yourself. Dr. Deshpande.
Sir, please unmute yourself, sir.
Hello. Am I audible now?
Yeah.
Yeah, you're audible. Please go ahead.
At the onset, on behalf of all SPOCI executive directors, members, and the contributors, I'm very much thankful to everybody, all the contributors and the panelists, everybody, including the sponsors of this particular program of myopia prevention and retardation by entire pharmaceutical and their team. They have really taken a very good initiative in the interest of mankind, so that this particular burning topic of myopia, which is increasing day by common and becoming more common, we must do something as a member of SPOCI and as a consultant in pediatric ophthalmology. We must do something in the interest of humanity. Again, I'm thankful to Mr. Marke and their team, entire team, for taking initiative for this project. And let me special thanks to my secretary, Dr. Pandey, who is doing a lot of work for editing, compiling everything all the day and night since last almost 1 year. And now we have come out with a very good bulletin, and I'm sure that it will be helpful to prevent and retard the progression of myopia all over the world for our precious new generation. Again, I'm thankful to all the participants today. They are sparing their time on Sunday also. They are sparing their precious time, and thankful. Dr. Pandey should go ahead with the program. Thank you very much.
Thank you, Dr. Deshpande. It has always been your constant support and encouragement, which has been really pivotal in bringing out these very nice guidelines with, of course, support of the entire NTOD team, which also have worked very hard. So now we start with our talks. The first talk will be given by Dr. Siddharth Keshavani. He is a pediatric ophthalmologist from Bombay, and he'll be talking on emmetropization and evolutionary underpinnings in relation to myopia. Dr. Siddharth has a lot of experience in myopia management and in pediatric ophthalmology. Dr. Siddharth, please.
Sir, Dr. Siddharth, he is facing currently the low network issue. So we will go on to the next second speaker, sir.
So next talk is by Dr. Shubhangi Bhave, and she will be talking on low dose atropine with other modalities. Dr. Shubhangi is president-elect of our SPOCI. She is at Nagpur, and she has very extensive experience in pediatric ophthalmology and strabismus. And she has been president of so many organizations. She has been office bearer and president of so many Maharashtra organizations. And practicing at Drishti Eye Clinic and Squint Center since 1994. Organizing chairman, MOSCon 2019, and president-elect proposed live member of various ophthalmic societies. President Vidarbha Ophthalmological Society, she has held all these offices. President of Nagpur Academy of Ophthalmology, recognized postgraduate teacher by Nagpur University, publications in various national journals, and pediatric and general ophthalmologist since last 40 years, GMC Nagpur alumnus. Dr. Shubhangi, please.
Good morning, everyone. At the outset, let me thank. Am I audible and is my slide visible?
Yeah. Please.
Fine.
Yes.
Go ahead.
Yes. At the outset, let me thank SPOCI for asking me to speak on this myopic pandemic, which has taken the world by storm. And also thank NTOD and Mr. Raman Marke for facilitating all these things and helping us out with bringing out the bulletin. So today I'll be speaking about on the role of low-dose atropine in myopia. The global prevalence of myopia has seen an exponential rise over the last few decades, especially in the younger age group. Myopia is reaching epidemic proportion and is now a public health challenge. The impact of myopia is not only related to ocular health, but also it affects the quality of life. Our understanding of myopia has increased tremendously. And since, however, many pieces of the jigsaw puzzle remain unsolved. Myopia prevention and reversal of its progression with the use of pharmacological agents has been known to be the most efficacious method. However, only atropine sulfate has shown consistent results in this regard. Coming to a historical perspective, optical and surgical corrections of myopia are only concerned with improvement of visual acuity. They have nothing to do with control of myopia progression. Numerous studies have been performed to establish the efficacy or the role of atropine in myopia progression. The earliest study on the effect of myopia were performed by Bedrosian et al. And Gimbel et al. In 1966. They used 1% atropine eye drop in myopic children and concluded that it was effective in halting myopia progression, but had a lot of adverse reactions. Also, its effect on eggshell length could not be ascertained due to inadequate data. In 1999, Shi et al. Used 0.25, 0.5, and 0.1% atropine eye drop in 200 myopic children and proved that lower doses were more tolerated and effective in slowing the myopia progression. Now, how does atropine act in myopia control? Now, atropine is a non-selective muscarinic acetylcholine receptor antagonist.
Yes,
the muscarinic receptors are abundantly found in iris ciliary body, ciliary muscles, lens epithelium, retinal pigment epithelium, amacrine cells, choroid, and scleral fibroblasts. It was initially thought that atropine works by causing paralysis of accommodation, as the driving force for accommodation was excessive accommodation. However, few studies have shown that eyes that are incapable of accommodative due to lesions in the third nerve nucleus also end up with myopia progression. Hence, the focus then shifted to non-accommodative mechanism of action, and atropine is known to modulate several biological processes to delay myopia progression. Atropine binds to muscarinic receptors on retinal amacrine cells, which release dopamine, and this has been correlated with reduction in axial length and slowing of myopia. Atropine also has a direct non-muscarinic effect on scleral fibroblast, which inhibits the glycan production and reduces the eye growth. So there is a robust evidence for the role of atropine in slowing of myopia progression, but mechanisms remain poorly delineated. Now, coming to the dose and side effects, many studies have evaluated the relationship between concentration of atropine and reduction of myopia progression. They found that nightly instillation of 1% atropine eye drop effectively slowed the myopia progression. However, adverse reaction including mydriasis, cycloplegia, and accelerated or rebound progression on cessation limited its clinical use. Consequently, the interest shifted to lower concentration of atropine, which slowed progression in a dose-dependent manner. Low-dose atropine is well tolerated and does not cause rebound progression on cessation. It was also found that efficacy of atropine was not dose dependent. It could be 0.01% or 1%, but the side effects were definitely dose dependent. Certain clinical trials which make us, tell us the efficacy of atropine. The ATOM-1 trial was, acronym for Atropine for Treatment of Childhood Myopia, conducted by Chua et al. In 2006. Randomized double-blind placebo-controlled trial was done. 400 children between 6 to 12 years with moderate myopia of -1 to -6 were randomized in two groups. Treatment group received 1% eye drop at bedtime, and the test group had no drops in the fellow eye. Control group received placebo in the test eye and no drops in the fellow eye. So the results showed that the study concluded that high concentration of atropine 1% was more efficacious but was associated with more adverse reaction. It also caused rebound increase in myopia after stoppage of treatment. The ATOM-2 trial was conducted in 2012 on 400 children. The aim was to evaluate low concentration of atropine for myopia progression and determine the lower optical concentration for the same. So they conducted the study with 0.5, 0.1, and 0.01 concentration of atropine were randomly allocated. Mean myopia progression was studied over 2 years. At the end of 2 years, the children treated with 0.01% atropine as compared to those treated with 0.1 and 0.5% showed a decrease in the mean refractive error. However, decrease in mean axial length was not significant. Side effects were much less with 0.01%, and rebound increase in myopia after stopping atropine was much lesser with 0.01%. Limitation of this study was there was no placebo control group in this trial. LAMP trial was done, which is low-dose atropine on myopia progression, was conducted in 2009 to address the limitation of ATOM-2 trial. Atropine in concentration of 0.05, 0.025, and 0.01 and placebo they used a placebo in 438 children between 4 to 12 years of age. So at the end of 2 years, they concluded that efficacy of 0.05% atropine was double than that of 0.01% with respect to myopia progression. All concentration were well tolerated with less side effects. Indications, now coming to the indications of low-dose atropine, just consider the case scenario 1. Your 9-year-old male with a diminution of vision for distance, both the parents are myope, was prescribed for the first time -4 spherical in one with -1.5 SIL, and left eye -4.5 with -1 cylinder at 180. And patient was started on low-dose atropine, 0.01%. So was it right? What went wrong? the patient was started on atropine at the first visit itself. Low-dose atropine therapy is indicated only to slow the progression of myopia. Hence, any myopic patient should be first follow-up at least for a period of 6 months to look for a progression, and that is for increase in myopia and or axial length. If the increase of myopia is more than 0.5 diopters per year, then the treatment with atropine may be started. Hence, there's no rationale for starting atropine at the first visit. Case scenario 2, a 3-year-old female, history of looking closely at the objects and deviation of the eyes. There's history of premature birth, low birth weight, and developmental delay. Both the parents are myope. Fundus examination shows myopic macular degeneration. The refractive error as shown is very high. Follow-up at 6 months and 1 year done, and myopia progressed by 1 diopter. And she started on 0.1% atropine after 2 follow-up visits. But in case low-dose atropine is indicated in myopic children in 5 to 15 years of age with progression of myopia, which is more than accepted for the normal age, and for the myopia of 1 to 6 diopters. It has no role in pathological or syndromic myopia. So we should, as I've said, start atropine between 5 to 15 years and showing myopic progression, which should be more than 0.5 or 0.75. What is the optimum dose? Normally, we start low-dose atropine in the concentration of 0.01% at bedtime, because this is the only concentration at present available in India. Reasons being there are less side effects and less rebound increase in myopia. So once nightly application is done, and duration of treatment, normally we give up to 2 years, but also depending on the age of the child, we might give for a longer time with assessment of myopia and axial length progression every 6 months. Now, how to handle poor or non-responders? In addition to atropine, some prophylactic and preventive measures can be done. So lifestyle modification in form of physical activity with sunlight exposure, a minimum of 8 to 15 hours per week is recommended for school children. Limiting near work, avoid continuous work for more than 45 minutes at one time. Follow the rule of 20-20-20. Avoid work in dim light. Reduce the screen use. Any additive treatment options with atropine? So optical measures like DIMS and HALT, which are the spectacle which take care of the peripheral defocus, these can be combined with low-dose atropine. It has been found that there is no increase in the glare, or there is no decrease in the vision with these glasses who are on low-dose atropine, and they work in unison or they have an additive effect. Similarly, we can combine low-dose atropine with soft dual or multifocus contact lenses, or with orthokeratology contact lenses, because atropine works on the afferent arm of the myopia, and these act on the efferent arm of the myopia. Now, just a word about pre-myopia. Is there a role of atropine in it? Essentially, pre-myopia is essentially a non-myopic refraction with high risk of progression, defined as refractive state of the eye between 0.75 to minus 0.5 in children, where there's a combination of baseline refraction, age, and other risk factors provide a likelihood of future development of myopia. Low-dose atropine may be started in such patients. This I am not very sure about the statement, but there is still a consensus about this. And thanks for a patient listening.
Thank you, Dr. Shubhangi. I think we need not because these are in evolution, and as time passes, as we learn more, we will learn more. At the same time, optical measures and atropine, they don't always may act as additive. We have some literature with orthokeratology and atropine, but with the spectacles and atropine, because afferent arm and efferent arm, does afferent arm also end up there? And atropine can help by about 60%, 70%. So the additive effect may not be very much, and then you can increase the concentration of atropine. If it is not working in a particular concentration, say 0.01, you can go to 0.025 or 0.05, which was in atom 2. I think there was some little oversight in atom 2 concentrations. I think it was 0.05, 0.025, and 0.01. And then Lime said that 0.05 is better. So I think these are in formative stage, and we need to take them with pinch of salt. And as we learn more, probably we'll understand things better. Anybody else would like to say anything? Dr. Sableen?
So one of the things that the ATOM studies have shown us, that even though there are so many treatment options for myopia, one that is safe, one that is cheap, and one that is very easy to use and which can be used all over the country, even in the rural and the most remote areas, is low-dose atropine. So this is, I think, a message that SPOCI should give out to all the practicing ophthalmologists, and perhaps even general physicians and pediatricians, because they also see a lot of children. And I think this is where NTOD can help us a lot. I mean,
Yeah,
we can do a great service to our nation.
That's a very valid point.
Hello.
That's
Only
very valid
thing
point.
is
And in
the-
Asian population, atropine is supposed to work better, and it may not work initially. It may take little time. So don't give up just initially if it's not working. It may take 6 months to 1 year to show its effect. So it's a very good therapeutic modality. And in our country, far-flung areas, poverty, this is, I think, a very boon. I mean, a boon to our population, because those spectacles are quite expensive, costing about 15 to 20,000, maybe more, and they might need to be changed, and other issues with fields and all. So that option is there, but I think this is the best option which we have.
Only
Dr.
thing-
Shreya, you want to say something?
Just one point. Only thing is that the indication should be made clear to everyone, because we have seen that we get atropine prescription left, right, and center. So that should not be done. It should not be misused. It should be used properly.
Dr.
That is very
Shubhangi has
important,
covered
yeah.
very well in atropine. I just have a question, Dr. Shubhangi. People are saying that even there is a rebound effect, or there is a non-responders. Have you tried increasing the dose of same 0.01 frequency of pain, same 0.01 like BD? Have you any? Do you have any experience for that increasing the frequency of the same dose? Or you think that the increasing the dose works? Because in atom 2 it said that even initially you find that the efficacy with the more high dose is good, but later on if you continue with very low dose 0.01, the effect is same later on. So have you ever tried increase the
I
frequency?
have not used. Only in 1 or 2 cases I have advised a BD application. But sometimes even if the 0.05 is not available, some say that 0.01 you can put twice at night. So if you don't want to give it in BD dose.
So that will not work the same way, because the concentration is low and
know,
it's not
but
commercially available in our country. I think NTOD people are bringing out a higher concentration.
Yes.
Have they brought out or
Yes,
not? I do not
yes.
know.
So
I
it is
think
said that
0.025 they were bringing out.
Yes.
But
yes,
once
it
it's
is
not
future
available,
will be 0.05. Yes.
yeah, and it's not easy to make at in a pharmacy, because there could be medical legal issues, and somebody gets into some conjunctivitis or something.
Yes.
It can be a lot of unnecessary hassle. So I think let's stick to what is commercially available and approved by our drug agencies. So can we move on to the next talk with that?
No, let me ask you one question. Hello,
Yes.
am I audible?
Yeah,
Yes,
yeah,
sir.
yeah.
Yes.
Dr. Shubhangi, you are an absolutely well-studied person. You have done a good job today. And I must appreciate Dr. Parikshit Gokte. He has raised a very good point that we should include the frontline warriors, that is the children specialist, along with our SPOCI team. We have conducted one seminar like that. We have included all the pediatricians in area of Pune, so that we can tell them, and these are the frontline warriors. They can guide, they can send these children as early as possible to us, or they can even start treating with low dose atropine also. or we should include at least them, especially for diagnosis at the earliest age in different, like congenital glaucoma, and so many things are there, because they parents usually take advice from the parents, from the children specialists. All the parents, they first go to children specialists when they start taking the Apgar score and all the other things. So this is a very good point. We must have collaboration with those people, and we must do something. Thank you.
Yeah, I think we need to involve pediatricians, school teachers, and parents. I
Yeah,
mean, that kind of
yeah,
awareness has to be there, and that has
yeah,
to be
yeah,
done
yeah,
in a very organized way to make it
yeah,
effective.
They
It
can't
has
be
to be done
made
like a
to,
movement.
they can't be made to prescribe the drops. The child has to
True,
be
ma'am.
seen by
True. Mayan of
pediatric
that is true.
ophthalmologist,
That is
because
true.
we need
Yes,
to
we
look
should not
up the
allow.
child properly before
Yeah, we
starting
should not
the
allow.
low
Correct.
dose
You are
action.
correct.
No,
You are
the
correct,
point is they
Subhani.
don't even get refraction done. The pediatrician should understand that the child has to be refracted by at least 3 years of age. Once that's not done, we don't even know. And if child is already myope at 3 years, he can be prescribed atropine drops. There is no contraindication. If we can show evidence that it is progressing, one can do. And now we are prescribing in pre-myopia also. So that is a huge population to be catered, because these pre-myopes will convert into myopes, and these myopes will go into high myopes. So it's a chain reaction. So we have to catch them young. So catching them at pre-myopic stage, of course, there have to be indications. There has to be some clarity what we want to treat and how we want to treat. But I think it's important to catch them young, and of course, with little surveillance and keeping those parameters in mind, it needs to be done.
Can I add a word?
Yeah, sure.
I'm sorry, I came. We had another meeting here, that's why. Uh, Actually, we do have a lot of screening programs in school now to screen visual acuity in children. But I think we should reinforce this as screening should be done at the age of 3 or 4 when they go to school for the first time. That should be made mandatory at the governmental level. Then only we can detect whether they have a defective vision or not, for so many other purposes also, but myopia also. Often with an anisometropia, sometimes they don't turn up until very late, and there's no point starting late also. So I think screening should be made mandatory at the time when when the children go to school at the age of about 3 to 4 years. That I think with the guideline, I think we should reinforce this also in schools and at the governmental level, that they should have a proper screening done before at least 5 years.
3 years.
Yes,
That's
ma'am.
the right
Ma'am,
age, I
in
think, because we
Pune,
had school health
Yeah, 3
program,
years
but
is the
it's not
age.
being implemented. And those children who have strabismus or who are likely to have poor vision, they need to be screened earlier, maybe at the age of 1 year.
Yeah, when
Problem
we
is they
make
go on
our
till
guidelines, I think we can add this point also.
yeah.
Dr. Leela ma'am, actually this issue was taken up with the health minister, Mr. Ambumani Das, at that time during the SPOSI conference at Chennai. He assured us that same will be implemented. I followed up it with the next minister, Ghulam Nabi Azad, but nothing concrete has been done. I think SPOSI can further take up this matter with the concerned authority. Yes.
I think we need to do it because it's very important. It's a public health issue, and we
Yes.
will slip into more and more of morass if we don't act now. So I think with that we come to the next talk. Anybody
Sir,
else want to say something, or we move on to the
Siddharth
next
yes, sir.
sir
talk?
has
I just wanted
connected,
to.
sir. We will take the
Sir, may
second
I
talk
add?
from the Siddharth sir.
No, Dr. Gopta is saying something. Dr. Parikshit, you were saying something?
Yes, sir. We have done a study in Anganwadi children in Pune, 3 to 6 year olds, about 1,400 children, just before the pandemic, 2019. And now Anganwadis mostly cater to the poorer section. So it is done in the slums of Yerawada, Vishrantwadi. Even in them, in 3 to 6 year children, 6% of children are myopic. So it's not just the very rich schools or the very well off or rich children. Even in the poorest strata, because of use of mobile phones, because of more literacy, because of more indoor work, myopia is seen very, very early. So yeah, we publish.
Yeah, I agree with Dr.
Thank you.
Parikshit. Anganwadi workers definitely works, and we have already also tried this.
So with that, we move on to the next talk. That is by Dr. Siddharth Keshavani. He's a practicing pediatric ophthalmologist at Mumbai, and he'll be talking on e-metropolization and evolutionary underpinnings in relation to myopia. Dr. Siddharth, please.
सर ये इनका इंट्रोडक्टरी स्लाइड्स है.
Dr. Siddharth is consultant INR Eye Clinic, Boravali, Mumbai, ex-faculty LVPEI, MS Gold Medal, Minto Hospital, Bangalore, clinician, reviewer, researcher, speaker, several original papers, national and international journals. So he is a very experienced and very learned person. So let us hear him speak on e-metropolization and evolutionary underpinnings, which is anyway very vast and very deep topic. And I think this needs to be kept in mind when we are talking of myopia, because myopia actually has come from there only, from the ocean, from the marine life. Dr. Siddharth, please.
Yeah, good morning, sir. And thanks to the Honorary Secretary and Honorary President of SPOCI for organizing this meeting. And thank you for giving me an opportunity to speak. Now, today I'm going to speak about a very interesting topic. Just give me a moment to share my screen.
Rahul, you can help. It's, I think, bank book.
There is a glitch
Rahul,
there,
you can help. Rahul?
Yeah, I think, can you see my screen now?
No.
We can
I've shared my screen.
We are seeing your screen, but I think you'll have to stop sharing because you actually shared your this web page, not the
You can click on
PowerPoint.
screen share.
But I can see
he's
the
already
mouse.
sharing. Yeah, he's already shared. So, you just stop sharing and share your PowerPoint again because we can see your web page actually. You're sharing it, but not the presentation.
Okay, just a second.
Yeah, that's better. I think.
Now is it fine?
Yeah.
Yeah, that's good.
Thank you very much, and thanks for the patience. I got logged off initially, and now I'm back. So, in order to make our future better, we need to always keep a track of what has happened in the past. And when we talk about myopia, we have to really dig really deep into the past. Before I start the evolutionary underpinnings, there are certain very interesting things that I need to share with you. The eye evolved from a light receptor organ designed to regulate circadian rhythm and seasonal behavior in lower animals. So it was never intended to do the vision function. It evolved over a period of time to get vision. Initially, it was just a light sensor. The camera-like eye has evolved around 500 million years ago, and it evolved pretty quickly within a span of 100 million years, which in the context of 5 billion years of life on Earth is a very, very small blip of time. Many naturalists considered the eye to have evolved suddenly without any evolutionary progress because they thought it is simply too complex an organ to get evolved. And that's why for many years it was considered to be an organ which has just come out of the blue and did not have any precedence. But recent studies have shown that there are great similarities in eyes of land-based vertebrates with shark, octopuses, and squids. Eels and hugfishes are the oldest living ancestors of the human eyes that we can think of. With this interesting trivia, we'll go on to the next slide. The life migrated from the sea to land, and under the sea there was very less light, and the cornea water surface is not a very great refracting surface. So when it migrated to the land and was exposed to so much sunlight, it had to adapt itself. And the refractive surface between air and cornea is a very high refracting surface. So you can see the sea animals have very large and thick lenses, and human beings have very thin lens. And the retina had to really grow in order to accommodate all this light, to increase the field of vision and to increase the depth of vision. In lower animals, the field of vision is increased by having a compound eye, wherein each optical element is linked to one photoreceptor, and therefore there is an array of units which can lead to sensitivity of light in all directions. But in human beings, there is a pupil and there is a lens and there is a retina, and that's why it can only focus in one direction, and that's why the extraocular muscles evolved in order to move it in all directions so that you can increase the field of vision. Now we come to myopia. Why do diseases increase in prevalence? Well, diseases which are basically genetic in nature, and why do they increase in prevalence? They should ideally get eliminated by natural selection. So these are the following reasons why which diseases can increase in prevalence. Either they are getting diagnosed more frequently, or there is a demographic change in the population. That means a younger population means more myopia, or it could be caused by environmental changes like urbanization, where the change in food habits have happened and change in a daily routine has happened, change in sleep times have happened, or it is simply that the genes that are responsible for that particular disease, in this case myopia, also have a reproductive advantage over the other diseases. So this is called antagonist pleiotropy, wherein the particular disease gene is also giving a reproductive advantage to the animal, so that this gene propagates itself in spite of the animal having the disease. Now look at evolution. When we were in the Stone Age and we were hunters and gatherers not long back, by natural selection, all the myopes should have been eaten by lions and tigers. But that didn't seem to happen, because these myopes probably never went out to hunt and gather. They stayed back and they created the tools and they created the ornaments. Then when later on, when tribes started fighting, they didn't go to war, so probably they stayed behind and reproduced. So they were protected by a social system. And when spectacles evolved, there was an answer to the myopics, and that's why they did not have any disadvantage over their non-myopic counterparts. And probably they had a reproductive advantage. So this is how probably myopia survived through the ages. And it's a very interesting paper which is titled "Natural Selection Contributes to the Myopia Epidemic." Now, this is a very recent paper in 2001. I am sure many of you must have read it. What it has done, it has taken the populations between the 1940s to 1965s, and they have studied their prevalence of myopia today in that population, and they saw that every passing 5 years the population has a higher incidence of myopia. So what happened? Then they try to see whether the genes that are responsible for myopia also expressed themselves more in subsequent generations. And then they were surprised to find that a large number of myopic alleles actually expressed more in subsequent generations. That means they have some kind of a survival benefit in that organism. They also found that the rate of these alleles or these myopic genes was much higher in people who were producing children at an early age and who were producing a larger number of children. So the myopic gene, a certain alleles, at least 20-25% of the alleles that are responsible for myopia are giving some kind of reproductive advantage to the organism. And that's why the gene is still surviving and thriving and propagating itself. Now, it is selected against the reproductive rate. So if there is a phenotype of myopia and there is a genotype of myopia. Genotype is the person who is carrying the allele, and the phenotype is the person who is actually manifesting myopia. So you look at these two populations separately. Now, if you look at the myopes population as per se, they produce less number of children because they seem to be more educated. They get married later on. The child at first born is later, and then their reproductive age or the duration which we can get reproduce is lesser, and that's why they produce lesser number of children. But when you look at the population at large, the alleles which cause the genotypes of myopia are in a larger proportion in people who are able to reproduce more. So the phenotype, although is holding back the propagation of myopia, the genotype is actually undercurrent. It is propagating itself in the population. Now, what is the quantitative effect of this propagation of the myopic allele? Now, it is not a very large effect. It contributes to around 1.5 to 2% of overall increase in prevalence over 25 years. Now, 1.25 in the same time, myopia is increased maybe around 10% in the same population. So the remaining 8% increase is because of environmental factors, and this 1.5 to 2% increase is because these myopic genes somehow manage to propagate themselves by a higher reproductive advantage. The second evolution has happened in the diet of people. So as children or as societies became more urbanized, and you started doing collective farming, your diet was more focused on carbohydrates, and they are less carbohydrates become cheaper as they are produced in larger quantities. Societies focus on feeding the mass of population and not nourishing the mass of population. That's why always wheat is subsidized and rice is subsidized, and it is available at a cheaper rate to the larger population. Now wheat and rice flour are actually having a very high glycemic index. So when they go into the bloodstream, they create a sugar spike, and this sugar spike leads to hyperinsulinemia, which causes insulin resistance, which causes increase in the insulin-like growth factor, which again causes the growth of the body and the growth of the eye. So your height increases, you attain early puberty, and you become more myopic. The same other pathway is because you have more insulin-like growth factor, there is a down regulation of insulin-like growth factor regulation protein, which is also responsible for being a mediator in retinoic acid pathway in the retina. Retinoic acid secretion from the retina actually inhibits the scleral growth. If the binding protein is not there, then retinoic acid is not able to inhibit the scleral growth, therefore causing myopia. So this increase in carbohydrate rich diet, especially refined sugars, especially corn syrups, especially fast foods and snacks that children eat, also have contributed by increasing the insulin like growth factor. Now we come to the next aspect. Emetropization is stimulus driven. Of course, the child is not born with perfect eyes, and none of the animals are born with perfect eyes. Only when the light is being focused on the retina, that is when they try to adapt to the stimulus and focus the image on the retina, thereby altering the thickness of the lens and the length of the eye, and leading to emetropization. So this we know from certain animal experiments in the past, like form deprivation myopia and lens-induced myopia, wherein myopia was artificially created by either closing the eye of these infant animals or putting a hyperopic defocus in their eye. And then they showed that these retinas actually try to change the length or the distance from the lens in order to keep the image in focus. Now, when you stop this stimulus, they also tend to recover. So, in a growing eye, it can reverse also. So, in small children, you will see that when they are infants, they have -6, -7 myopia. By the time they are 2, 3, it can reverse also. So, when the child's eye is growing, myopia can reverse. That is probably an argument why you should not start giving glasses at a very early age, like 1 or 2 years of age, because that may inhibit the emetropization process. So this is overall flow chart on how the emetropization process goes on. There is a visual defocus, which leads to a poor retinal response, which leads to secretion of certain substances that lead to the remodeling of the sclera, increase the creep rate, and cause increase in the axial length. Same thing happens when the defocus is as a result of inadequate accommodation or accommodation lag, where the retinal defocus is causing the axial length to increase. That's how probably near activities contribute to increase in myopia. In conclusion, myopia genes also seem to have reproductive advantage, causing antagonist pleiotropy. Somehow, some myopic genes tend to survive and propagate themselves in spite of having a poor phenotype for survival. Evolving dietary patterns in urban societies play a role in increasing the prevalence of myopia. It's probably from the 50s and 60s where you are going towards a more carbohydrate rich diet. Proteins are costly, and all the other food groups are extremely costly because the entire agriculture is skewed towards production of carbohydrates and not of proteins. That's why probably is adding towards the progression of myopia. Emetropization process gives an insight into the probable mechanism of visual stimulus in environment of myopia, and probably can give us some preventive methods for preventing myopia in susceptible children. Thank you very much. Thank you very much.
Thank you, Dr. Siddharth, for a very insightful talk. I think this is for future. A lot of things will, as we learn more and more, a lot of things will happen. But we know that we all came from marine life, and if you go underwater, as you go down and down, less and less light. So the vision goes down, and it will sort of more divergent rays will induce more myopia because you need larger eyeball length. So it's a very complex matter. I think a lot of things need to be put together. Anyone would like to say anything on this?
Yeah, Dr. Siddharth has
Wonderful.
really he has elaborated about diet, the diet in children and their parents also. Multifactorial deficiencies, they play a great role in progression of myopia, as well as I have seen so many cases of myopic astigmatism also just because of imbalanced diet, especially the protein deficiency diet. So there is a definitely role in children about especially about the balanced diet. Thank you very much.
Yeah, actually, vitamin D and sunlight have also been linked with myopia, so more poor vitamin D levels, and so it's a very, I think, complex matter, and the pieces of jigsaw need to be fixed. Anyone else, or we move on to the next talk?
Sir, I have a question.
Dr. Savlin, yes.
I wanted to ask Dr. Siddharth, he briefly mentioned about emetropization and how we shouldn't give glasses to very young children. So I would like the experience of the panel on that. That do you want to undercorrect or not give glasses at all at a younger age so that you do not inhibit the process of emetropization, or because you're moving to a world which is going to be myopic, your threshold for glasses has gone down?
This is, I think, very complex matter. You can't leave them uncorrected as well. And how much ultimately this is going to affect process of emetropization, we need randomized trials, which are very difficult to perform. So I think it will remain a very controversial area from that point of view. But of course, if you undercorrect, then there is a problem. If you overcorrect, also there are problems. So I think somewhere, depending upon the clinical situation, we have to draw a line and act in whatever knowledge we have at that point of time.
No, but I would like to ask a question that with reference, especially the child is about 6 years of age or 7 years, and the starts with the myopia of -4 or 4 plus. Are you getting me?
Yeah.
Yeah. So at that point, as she has correctly asked, whether we should undercorrect by any small, by say one diopter or say 20% or 30% or anything of that kind, that we can reach to some consensus in this.
If you undercorrect, visual acuity is also going to drop. If you undercorrect, visual acuity will also drop. So, 4-year-old child, if you have undercorrected and vision is 612 or 618, that will also can create amblyopia. So it's a tightrope walk. I think one has to we have to correct vision to say at least 6/9. I think if it's not that, then we cannot leave it like that. That will be more damaging than the benefit will be less and harm may be more. I think.
I think the age is very important. 6 years is when the emetropization is complete. So this is already deviated from a emetropized eye. So you have to correct.
Okay.
But I'm talking about a 1-year-old child and 2-year-old child who incidentally you stumble upon some myopia, and probably you shouldn't correct because then there is still some time for it to mature.
Yeah, there are guidelines on refractive correction in small children. They are, of course, there you don't correct even larger hypermetropia until they are having a deviation. If you have an ESO, that's a different matter. So those are because the things will change. The corneal curvature, the lens power, all that is changing. But I think at the same time, emetropization is also going on slowly after 6 also. That is not that exactly it's going to stop at 6, but the process is much less after 6 years. So some emetropization goes on, some emetropize, some don't emetropize, some emetropize more, some less. So it's a Pandora's box. So it's not that all hypermetropes move on to emetropia. So it's a very
and there is another thing, sir. If we correct a small myopia or a not so significant hyperopia, then we have found that even the spectacle compliance among children is very less. It is less than 30%. So perhaps for very small myopia, like -0.5, -0.75, I think even if we don't correct initially, it is better. But of course, we will need more from all these stalwarts of SPOCY. So I think perhaps the next guidelines can be this as to when we should actually start correcting a children's refractive error.
I think -0.5 to +0.75 anyway we take within the limits of clinical emetropia, so that's a different matter. But guidelines have to be subject to how old is the child and what is their strabismus and other things. They are also important. So it has to be a comprehensive evaluation. of course, guidelines are already there. We can make our guidelines also on refractive correction. Also, I think we need to do that maybe. Thank you, Dr. Gogote. Then we move on to the next talk with that. And next talk is by Dr. Leela Mohan. She will be talking of role of digital media in progression of myopia. Dr. Leela Mohan is a very experienced pediatric ophthalmologist, and she has been working at Comtrust Eye Hospital, Calicut, Kerala. And she's been very regular with attending our conferences and contributing a great deal to our deliberations. Dr.
Thank
Leela,
you so
please.
much, Dr. Pandey. Thank you for giving me this opportunity to be part of this enlightening session. Actually, can you see my screen? Can you see my screen?
Yeah, we can see
Yes,
what
it is visible.
Is visible, yeah.
Just you need to do full screen.
Just full screen need to.
Okay.
Yes.
Yeah, that's fine.
Very good, very good. Go ahead, madam.
So
role of digital.
It's the role of digital media in progression of myopia. Actually, this has become more relevant after the COVID times, when we have already seen that with the increasing prevalence of myopia to as high as more than 80% in East Asian, some of the East Asian countries, and a prediction of 50% of the world population turning myopic by the year 2050, it's definitely relevant to know the factors inducing early onset of myopia and progression. And so what causes myopization? We have already seen nature versus nurture, genetic factors. We have seen Dr. Siddharth talking about it, and environmental factors which we are able to modify to some extent. Like time spent outdoors, near work, and peripheral defocus, which is the most important optical factor which we can modify. And genetics, as we have discussed now, with both parents myopic or one parent myopic, the chances of a child having myopia and these environmental factors inducing progression is much more. And as Dr. Siddharth has pointed out, myopia can be seen as a mismatch between the environment in which we evolved, that is outdoors in the natural light, and the modern day largely indoor life. Muscarinic ACH receptors in retina, dopamine, and nitric oxide are strongly implicated on regulation of eye growth, and exposure to light is supposed to alter these receptors. And immetropization also has been dealt with, but the corneal curvature becomes more or less stable after 6 years, and it is the axial length and lens power which may change due to the environmental factors, and which can be modified also. And so the stimulus for elongation of eye has been found to be the ocular growth and refractive development are regulated by visual feedback, while genetics determine myopia susceptibility, environmental factors which might even override the genetic predisposition in progression. Refractive errors can be induced through form deprivation and lens-induced defocus, as we know by the Hubel and Wiesel experiments in 1976. So peripheral defocus, also we know that the optical factors which modify progression are visual feedback associated with eye's effective refractive status, which regulates immetropization. And eliminating the fovea by laser photoablation did not prevent the response to peripheral hyperopia. So it is not just the central foveal visual focusing that is important. And peripheral hyperopic defocus is a stimulus for elongation of the eye. But coming to the fovea, near work includes activities with short working distances like reading, studying, doing homework, computer use, and playing video games. And association of myopia with educational performance and close work occupations is known since many centuries, and near work has long been considered an environmental risk factor. Myopia onset and progression have been associated with higher educational levels and near work, and myopic children have a greater amount of hyperopic retinal blur during near work than non-myopic children. So digital smartphone and tablet use has exponentially increased during the past decade, especially after COVID, and various studies and meta-analysis among more than 10 studies in various studies have shown progression of myopia among digital smartphone users with or without computer use and near work. But other factors may also be involved, like lack of outdoor activities, and it's not easy to separate near work activities with electronic gadgets from near work activities like reading a book or studies in children. So that is why most of the studies could not isolate a smartphone use alone and definitively conclude progression due to it. There are postulates. A study from China and in many other countries have reported a myopic shift during this COVID times, a 0.3 diopter myopic shift and 1 to 3-fold increase in myopia prevalence among children between 6 to 8 years during home confinement. And Joshua Foreman et al., in a systematic review and meta-analysis, could not definitively show the association of digital media and myopia progression. But it is postulated that the larger accommodative lags present during near work, which is higher in myopic children, due to the close working distances, would increase the peripheral hyperopic defocus further in myopic children. And increased accommodative effort required during near work has been proposed as a cause of myopia, and it has a role in progression. Its role in causing myopia has not been established. The variability in results of studies looking into accommodation near work and esophoria for near point point to the possibility of accommodation lag having a role in progression. So dynamic retinoscopy should be included as a part of examination tool in myopia guidelines. So the Generation R study done at Rotterdam among 5,000 children in 2002 to 2006 showed that there is increased computer use is associated with myopia development before the age of 10. The cumulative time of the computer in infancy was significantly correlated with myopia at 9 years. And the combined effect of all this near work could be compensated by outdoor activities, as shown in the Generation R study. But other factors have to be considered other than the near work, like chromatic content of the light emitted by screen, the blue light, luminance, contrast, screen flicker. All these should be considered in future studies. So it has been shown that studies have shown that blue light emitted from computer screens can produce retinal pigment epithelial dysfunction in mice. And in turn, it produces axial elongation and pathological myopia, and destabilization of retinal development can occur. A near viewing of digital device produces peripheral hyperopic defocus-induced progression factor also. So interestingly, the exposition to red light, that is 650 nanometer wavelength at home with the desktop light therapy device, had recently been shown to be effective in myopia control at the end of 12 months, published in 2022 in ophthalmology. So the environment of the use of digital device is also important. Lighting of the room and other computer hygiene when using these electronic media are important. And less exposure to outdoor activities and sunlight during confinement to indoors during smartphone use of more than 4 hours promote progression, which is shown by many studies. So recommendations to the use of digital devices and smartphones. The American Optometry Association has shown that myopia is more among children using smartphones for more than 4 hours a day. And guidelines published in Ophthalmology Journal in 2019 say that no screen time should be allowed for children below 1 year, 2 to 4 years, up to 1 hour, more than 5 years, less than 2 hours screen time per day, And the American Ministry of Education recommends spending less than 20 minutes per day on electronic homework and prohibits the use of phones and tablets in classrooms. I think we should also bring about guidelines so that a uniform pattern can be adhered to in school and at home. There are various schools use tablets, and many children who cannot afford computers, they use mobile phones for their study purposes. So I think we should go for some. We know that definitive proven studies have not been brought forth saying that electronic gadgets are the reason for progression, but definitely most of the practitioners suggest that the use of these more than the recommended period should be forbidden. Thank you.
Thank you, Dr. Leela, for
Excellent.
a very insightful talk. And only thing is that I think we need to learn that there is more illumination, and we increase the distance slightly from 25 to, I think, if you go to 35, 33 centimeters, that may probably help. I think that also needs to be put across, that when we are reading or doing near work, we should keep the thing, I mean, the mobile or the book slightly away, and it should have better illumination, and don't exceed about more than 45 minutes. If it is 20 minutes also, it is okay, but if it goes on for a very long time, I think that's also damaging. Dr. Deshpande, you were saying something?
Hello.
Dr. Deshpande, you were saying something, sir?
Yeah. Regarding the screen time management, American Academy, Canadian Academy of Pediatrics, they say that it should not be more than 30 minutes at a time in one session. And they should never use the small mobile phones, smart mobile phones. They should use tablets or bigger screens. So, and the illumination should not be more than 60% only. So this will not affect their vision at any time, or there will not be any stress.
And one study in India is also showing that there is a difference between a urban school screening program and very, very remote rural school screening program. And they found that the urbanized school children had more myopia progression than the rural screen, because for the really rural remote school children student have to go walk to the school, and they play also. So they are more exposed to sunlight. So that is a proven study, one proven study in India is there, and we are also doing that. And one more thing we can add, when we can add that when the child is sitting at home and reading or doing anything near work, if we tell them to sit near window, so by default, when the child looks up, it will look too distant, as Dr. Shubhangi also said, 20-20-20 rule, which can be followed if we instruct this. Thank you. It was wonderful talk.
Yeah, this urban-rural divide is already there. We know that.
Sorry to interrupt. Sorry to interrupt. There was a question by a parent that reading from the print media, will it also affect the change in the progression in the myopia than reading on the screen? Is there any answer on this?
This is what they have not been able to separate from. The child looking at the screen and doing homework from the book, they could not differentiate between whether the cumulative effect of the near work is the factor which progresses myopia, or whether the digital or electronic device is the one. Most of the studies could not analyze this. And it is not easy also, because we cannot ask the child not to read also.
Yes. So I could not give the answer to the parent when he asked this question. I said, I am unaware about this.
Yeah, a lot of things need to be learned.
We probably need more studies on this. And at the same time, I would ask any one of the faculty using red light as a modality, because even I have read about this red light which causes reduces the progression of myopia.
I think it's a bit expensive, and it's not a very simple gadgetry. Probably it's expensive proposition, I think, and it's not available. So one has to probably look up how to do it.
Yeah,
So
I
with
think
that,
we should definitely bring about some guidelines as to, like the American Academy, and as Dr. Our president was saying that they have brought about some guidelines. We should also bring about some guidelines as to how long a child can use, especially because children, the parents keep asking us how long. And we are, of course, we can say our own personal views, but I think we should have some standardized guidelines to say that under 2 years we cannot use it for more than a period. I think we should bring about that guidelines also.
yeah, I think
Yes,
20-20-20 rule is there, but I think that is quite safe to my mind. But people don't follow that rule. I think it's not easy to stop, So once they are into
Issue
it, they go on and go on. And children are very difficult to stop. And that's the age we need to catch. A child who is 2-year-old is more likely to get into difficulty and into myopia. Maybe if we can stop that at that age when they are young, I think that's going to be important. Those 2-year-olds, 1-year-olds who start mobile and doing
The
everything.
children are
Cartoons.
so engrossed in the digital media that if we call out to them, ask them some question, they're dead to the world. So
exactly.
If we have observed a child with a mobile phone, they're just unresponsive to anything.
So I would like to make a point to the question asked by Dr. Madhav Ambekar. So nowadays, now we are in the post-COVID regime, so we could at least ask the schools to stop giving the homeworks on the digital manner, and just like it is so addictive. So though the studies like Leela Mohan ma'am has said that it has not been, we don't have exact results, but at least we can wean them off from the study part, at least that the homework and all need not be given on the gadgets. So if we return back to the books, it would be much better.
No, young children, 1-year-old,
No, but then what has
2-year-old,
happened is the
3-year-old,
schools
they are
have
not doing
started saying,
homework. They are addicted to mobile since 6 months of age now. Once they start fixating, they fixate on the mobile. So I think that's the major problem. And if it happens in that age group, then obviously more myopia.
I would like to ask
Sir,
Dr.
issue is not
Pandey.
about the guidelines. Issue is about
no school
enforcement.
managements have,
Even during the time periods of patching, I do encourage children to do some video games. I don't know how far.
That's what we also do. Yes.
That's
It is even convenient for the parents to give a mobile phone to the child, so they are off the responsibility of looking after the child. So many mothers do that.
No, but then what Dr. Vaishali has said about the that I was stopping the homework on the mobile. But then in my city, at least, there are 3 school management people, those who have a lot of fights with the parent during the PTA, saying that we will have this only the way to give you the homework. So can it be said through the government regulatory authorities to that it should go back to the text media and the print media than the electronic media? Is it possible?
Impossible.
Government is not going to say that because of financial issues, lot of issues. They are not going to say that. I think they go by experience and
we
money.
can give the guidelines, sir, because now in the COVID COVID times, it was okay. It was the need of the hour. But now again, we can shift to decrease the usage of mobiles.
I think we need to protect our children. I think younger ones till 4-5 years. Uske baad things get better. I think we should stress on that these ones from 1 to 5 years, 4 years, that's most vulnerable age. I think so. Something needs to be done.
Afterwards, I think it is in the upper classes, in the after 6, 7, 8 years that they are exposed to or given homework or some work to do.
No, ma'am, even in primary school kids, once, twice, I told the child not to look at the mobile, and the mother said she is doing homework on it. So I was dumbfounded, like, what do we say that?
One school principal said tissue le lo aapke bacche ki.
And parents nowadays, just before 2 years, even they are not eating, they give mobile so they can eat. So that at least we can stop.
That's
1-year-old to 2 saal to bahut bada hai. They are busy with mobiles like addiction. They just, you can't do anything. Start howling, you can't do anything. So I think with that next we'll have a video from Entod, and after that we will move on to the next talk by Dr. Sabri.
Thank you so much, sir. So first of all, just I will like to thanks to Sposi entire the thing. I will just show entire corporate video. Thank you so much, sir. Over to you.
Thank you, Mr. One, for very nice video. Shall we move on to the next talk? Next
Yes,
talk,
sir.
shall we move on? So the next talk is by Dr. Sableen Kaur. Shall we move on to the next talk? Mr. Raman?
Yes, sir. Yes, sir.
Yeah. So next speaker is Dr. Sableen Kaur. She'll be talking on low dose atropine. That is a very favorite topic and she has done extensive work on it. She's from PGI Chandigarh. We all know she's a very hardworking, sincere and dynamic person. She has been my ex-student from Guru Nanak Eye Center and she has over 100 index publications. Visiting fellow to Jules Steen Eye Institute, University of California, FICO, FACO in pediatric ophthalmology, member WSPOS and member AAPOS. She's got awards like Best Paper at AAPOS Annual Conference, New York 2023, and Best Paper Awards POSI Annual Conference 2023, Professor A.K. Corona Award, and area of interest is strabismus surgery, imaging in pediatric ophthalmology, ocular genetics, and refractive error in ROP and myopia. Dr. Sableen, please.
Thank you so much, sir. Thank you, Todd, for facilitating this very important topic and topic of discussion and debate, and a topic which can actually bring a lot of policy changing. I see a lot of teachers, so very good afternoon to everyone. And Dr. Shubhangi ma'am has actually covered what I was going to speak today, so I'll just quickly brush through some main points about low dose atropine for myopia progression so that we can discuss more. We have seen a decade which has seen an epidemic of myopia with increasing prevalence worldwide, and we have a plethora of literature now which is talking about retarding the progression of myopia. There are a lot of factors that have already been discussed, including age, parental myopia, ethnicity, and excessive near work being responsible for myopia. And in Indian children, there's a prevalence noted about 8.5% in urban population, which I think is underreported because we do not have any national screening guidelines which actually detect the prevalence, but we are just reporting what is coming to the hospitals. There are various theories of progression in myopia, primarily the commutative lag and the peripheral refraction theory. And based on this, we have certain modalities which can actually control the progression of myopia. Amongst the available literature, we have a lot of meta-analysis now coming up which have shown that pharmacotherapy is currently one of the most recognized therapies for myopia control. The mechanism of action of atropine is multiple. It can be by a neurochemical cascade. It has been shown to have an anti-inflammatory effect. It also acts on the scleral fibroblasts, which I think is the most accepted theory because it inhibits the synthesis of a glycosaminoglycans via a non-muscarinic action and also increasing dopamine from the retinal signals. Now, briefly, points about whom do we treat with atropine. The most important point, take-home message for us is that we should document progression in children, which is about 0.5 diopter in the last 6 months, and documented axial progression. So, along with the change in refractive error, we should have baseline and an axial length measurement at 6 months, which is reflecting that it is actually an axial progression. Most of the trials comment on this atropine therapy in children aged 6 to 12 years, with some going as low as 4 years. But we do not have evidence below 4 years that we prescribe atropine or not. The ideal atropine concentration has actually been studied in quite a number of trials, and we want a concentration that should show maximum efficacy have least side effects and cause a least rate of rebound myopia. So we have multiple trials that Dr. Shubhangi has already discussed, and I would just give a one-line review of all of them. The Atom 1 studied 1% versus the placebo, and they said that it has a very good efficacy but has more side effects because of its more concentration. The Atom 2 studied zero point 0.5, zero point 0.1, and zero point 0.01, and they saw that the side effects as well as the efficacy is dose dependent. So, because we have the availability of 0.01% in our country now, and it is the lowest concentration studied in Atom 2, it was considered as the most effective one with minimal side effects and the least rate of rebound myopia. The Atom 3 is currently ongoing, and it is studying children which are at risk of myopia, maybe with a parental history or maybe with a higher threshold of baseline myopia. The LAMP and the Indian Atom study subsequently studied children with 0.01% atropine, and because these studies did not have a large follow up and a comparison group, we still have more evidence to be looked for. Contrary to what Asian studies have published, there was a study by Michael Repka et al., currently published in JAMA recently in July. They actually negated the effects of low dose 0.01%, saying that it works in Asian eyes and not in the Caucasian population. So currently, they are not propagating 0.01% for the myopia control. What we can do in our country is a scenario that we have a axial length and cycloplegic refraction, which we document and then document progression after 6 months. It is safe to say that 0.01% can be a very effective therapy, which can be given once a day for myopia progression. We do a first follow up at 3 months. We document whether the patient is compliant to the drug and there are no atropine related side effects. Then we reassess with the cycloplegic refraction and axial length. It is important to document the progression even after we have started drops because the end point is still not very clear. We know that treatment is usually given for 2 years because most of these studies indicate so, but we do need to have some evidence and some experience-based practice in this regard because we might see progression as high as up to 18 years, and it is always difficult to differentiate whether they have reached a plateau because of their physiological decline or because the drops are working. In non-responders, there are very few studies which talk about higher dose. Of course, we can shift on to available doses 0.05, 0.05 and then 0.1 and 1%. More frequency is what people talk about, but it's actually not, there's no evidence talking about 2 drops at the same time or a BD dosing of 0.01. The cumulative effect of atropine needs to be studied in vitro and in vivo samples. A combination of modalities can be tried. We can shift on to atropine with these multifocal spectacle lenses. I personally have no experience in shifting modalities. So a non-responder atropine, if shifted to another modality, I don't see that working because we might have the side effects of rebound myopia, which we might confuse with non-progression on the other treatment modality. We should follow up these children at least at 3 months and then a minimum 6 monthly cycloplegic refraction. And even after discontinuing treatment, we need to assess them 6 monthly at least for an interval of 1 year. There can be various side effects, including a blurring of near vision and photophobia. Because these are cycloplegics, so they might induce an esophoric effect in eyes, and that also needs to be documented. And a rebound effect, I think, also needs to be looked at. It's not a side effect, but I like to mention because as we had discussed earlier, a lot of people start atropine in the first go. So it has no effect if there is no progression, and it has no effect in other forms of myopia. So not only is it important to document progression, we need to document that it's an axial progression and not lenticular or index or other forms of myopia, because atropine will work only on the axial type. So to summarize, there is a dose-related atropine response for myopia control. We do have the efficacy of 0.01% established to be in the range of 60% in most of the studies. About 1/3 of these children may benefit from a higher concentration also, especially if they are younger and they have a family history of high myopia, and high dose atropine can be made available to them. 10% overall may still respond poorly, and so we have to monitor them for a rebound myopia, and they may require photochromatic glasses if we are shifting them to high dose because we might see more side effects also. With documented axial progression, however, 0.01% atropine once a day, along with their appropriate refractive correction, is an effective therapy at present, which is the therapy of choice amongst all ophthalmologists. My acknowledgements to Dr. Jaspreet at Advanced Eye Center, PJ. Thank you.
Thank you, Dr. Sabreen. I think very nice presentation. And atropine, I think, is a sheet anchor in our setting, a poor country, and Asian eyes are known to respond better to atropine. So I think, as per the present evidence, I think 0.01 atropine can be started relatively safely. Of course, we have to document the progression, and those monitoring has to be done. And also in pre-myopes, we need to look at that huge population. Which ones of those need to be treated with 0.01 atropine? And you rightly said that about 90% are going to respond to 1% atropine. So those 10% who don't respond, we don't know what are these 10% which don't respond at all, maybe. And then, of course, those who are high myope, those who are, because of ROP, that myopia is not going to respond to atropine by and large. So if you are in pathological myopia, less response. That also has to be kept in mind, that if you are treating with that population, so they are not likely to respond. Anyone?
I have a question.
Can I
ask a question?
Dr. Rishikesh, yeah.
I mean, the progression, do you measure by axial length or only refraction? I mean, suppose there is a child, after 6 months you follow up and you find that there is an increase in the axial length, but the refraction is the same. So will you start diluted atropine for him, or wait for some time?
I think refraction should be better criteria than axial length. To my mind, axial length, of course, is a marker, but maybe it is emetropizing in whatever way. So if there is change into other parameters in the cornea, in the lens, so ultimately it is the refraction which is, I think, should be more relevant. Sabreen, do you like to say something on it?
So yes, spherical equivalent is actually our outcome. The outcome that we are looking at is actually the spherical equivalent. A lot of these studies which have done, their proportionate increase in axial length is not the same as that in the spherical equivalent. But if we see a spherical error being, increasing, that is what we consider as progression more than the axial length. There might be a discrepancy, because even in the ATOM and the LAMP studies, the amount of axial length progression did not correspond to the amount of increase in spherical error. So just an axial length progression and not reflecting on the spherical error, I do not consider that as progression. If it is more than 0.5, or if there is a discrepancy in the measurement, sometimes the machine reading is not the same. The way it is measured, where it was measured, I do take that into regard, that whether it's actually showing some progression of 0.25, 0.5 error in the hand of a optometrist might also induce. Taking that into consideration, a pure axial progression is not actually considered evidence of progression.
And as far as the documentation is concerned, we all should, before starting any treatment for myopia progression retardation, we should ask for the history of VKC, which we are overlooking. Whenever there is VKC and rubbing of eye, at least we should send child for topography to overlook the keratoconus at least. So just looking at only axial length, we can just add this point to our documentation.
More work needs to be done on this, correlating axial length with dioptric power.
Yes, cycloplegic refraction should be the
that is the main parameter. Yeah, that's true. That's the main.
No, but then atropine is to be started at exactly how much increase in the refractive power it should be there.
If there is more than 0.5 increase, then those cases
is it
you can
0.5 or 0.75?
0.5 by
0.5 and more in 6 months.
More than 0.5, yeah.
Okay.
Because some increase will be there. Some increase can be there, 0.25 or so, whatever. So you can't start treating 0.1, 0.2. It may not even be very easy to measure those minor differences. So I think that is a good cutoff. That is, I think, a good cutoff, 0.5. So if it is less than that, probably it need not be treated. So close follow-up will be required.
But 0.5 to be at a change at 6 years and 0.5 change at 9 years or 10 years. What should be the guideline?
It is 0.5, more than 0.5 increase in 6 months. That is important. Whatever it is, say from 4 to 4.5, or increase should be by more than 0.5 diopter.
0.5 diopter minus 0.5 diopter is known as anatomical error. So better to forget that. More than that, you can start.
It is cycloplegic refraction.
Yes, it's correct. Okay. I'm talking about the cycloplegic refraction only. Yes. But 0.5, this error is known as anatomical error. Unless the child has some astronomic symptoms, it is better to forget.
I have most of the guidelines say a minimum of minus 0.5. How can we start at minus 0.5 unless there is a progression of minus 0.5? Then it has to be at least minus 1.
So we are talking about progression. We are not talking about the absolute.
No, I mean the baseline start. Unless you have progression, you don't start.
Yeah.
So myopia should be at least minus 0.5. That is the guidelines in most of the studies. But I don't know how we can justify minus 0.5.
Progression of 0.5.
Yeah, progression means when the patient comes for the first time, you don't know whether there is progression or not.
So you have to wait for 6 months.
We record them for 6
Wait
months.
6 months and then see. And that's the progression at 6 months, I think. So with that, we move on to the next talk. That is by Dr. Kalpit Shah, and he'll be talking on optical treatment for progressive myopia. Dr. Kalpit Shah is from Ahmedabad. We all know about him. He has been doing a lot of work in pediatric ophthalmology. He's associate professor at M&J Western RIO Ahmedabad. Dr. Kalpit, please. He has been a very regular.
Good afternoon, sir.
Has been attending our conferences very regularly. Of late, he has not been coming. I would request him to come to Rishikesh this time. Dr. Kalpit.
Yeah. Thank you, sir. Yeah. Is it visible, sir?
Yeah.
Yes, sir. Just you can make it the full screen. It's visible.
Yeah. I'm trying for that. Yeah.
Perfect.
Yeah. Good afternoon. Today, just I'm going to discuss about the different glasses available for progressive myopia. Like as we already discussed that myopia incidence is increasing day by day, and by 2050 it would be the half of the population would be myopic. And there are different factors which I tell, like normally parents ask every time what could be the reason. So I tell it's a multifactorial, the incidence of myopia increasing. Either it could be due to genetic, optical, means the near work activities, and the environmental factors. So to discuss about the glasses available for progressive myopia, first we have to understand that the theory of the peripheral defocus theory. Like when the myopia is uncorrected, like Siddharth has already discussed, that what happens that the central rays are focusing in front of the retina, but in the peripheral part of the retina, because of the curvature of the retina, the peripheral rays are focusing behind the retina. So there is always a stimulus for the eye to progress to get the peripheral rays exactly on front of the retina. So there would be a immetropization process continuing, or we can say the axial length elongation. Now, when we give the glasses, normally what we were giving the single vision lens. So by giving the concave glass, what happens that the central rays now focusing exactly on the fovea, but at the same time, because of the curvature of the retina, the peripheral rays are focusing still behind the retina. So there would be a peripheral defocusing of the rays. And because of the hyperopic defocusing, the stimulus to axial length elongation is continuing, and because of that the myopia still progress. So there is a need that we can give the glasses, by that we can focus the central rays exactly on the fovea, and at the same time the peripheral rays also focus exactly on the retina. So there would be a slowing down the myopic progression. So to give that answer, there are different type of glasses nowadays available. That Hoya is come with the MioSmart, that is a DIMS technology, defocus integrated multiple segment. The Essilor has come with the Stylus glass, and that is based on the Hall technology, that is called the highly aspherical lenslet target technology. Zeiss has come with the trade name of MyoCare, and it is based on the CARE technology, that is cylindrical annular refractive elements. And Nova has come with the novel technology. Like normally we give the progressive addition lens that is from the center to the down segment, but instead of the vertical portion, there is a horizontal progressive addition lens, so that the rays focusing on the peripheral part will be on the retina. Now, instead of the defocus theory, if there is an accommodative lens, we can simply give the progressive addition lens. And there are availability of the contact lens, like soft multifocal contact lens, the orthokeratology, and for the defocusing, there could be a MiSight contact lens or the ability from the AccuView. But today we will discuss mainly about the defocusing glasses, the spectacle glasses available for the defocus theory. The first one, that is the Hoya MioSmart, that is based on the DIMS technology. It has a central clear zone that is around 9.4 millimeter for the central vision. While in the mid periphery, they have a different types of the treatment zone, we can say. They have a DIMS segments, and that is in the central 33, the mid periphery 33 millimeter area. And here the shape of that segments in a honeycomb appearance, and the power of the lenslet would be everywhere. It is 3.5 millimeter, 3.5 diopter, that is a hyperopic. So when the child is looking from the mid periphery, so from the treatment zone, what happens in the pupillary area, there would be the 50% area of the central zone and the defocusing zone. So when child is looking through this mid periphery, he would have a clear vision even from the periphery. But as we know that still there is some lacunae in the MioSmart glasses. Then when the child is looking from the mid periphery, they say that there is some cutting of the vision, or they can say that the peripheral field is little bit decreased and there is a blurring of vision from looking at the periphery. And for that, the monocular IPD is very, very important for the that Hoya MioSmart lens. Then the second come, that is the Stiles. That Stiles is from the Essilor lens, and that is based on the Hall technology. That is a highly aspherical lenslet target technology. Here there is a central 9 millimeter clear zone, and in the periphery there are total 11 rings, and each rings having a 1.12 millimeter diameter lenslet. And total there are around 1021 contiguous aspherical lenslet, and they are touching each other. So, but the lenslet power is increasing from the center to periphery. So here, instead of the common same power, the power of the lenslet are increasing from the center to periphery. So the periphery, we can get more defocusing. So the periphery, we can also get the focusing on the retina. The space between the rings for single vision distance correction would be there. So here there would be a volume of myopic defocus. Here there is not a single myopic defocus, but there would be a volume of myopic defocus. So because of that, both the peripheral defocus and simultaneous defocus would be there, and it will give better correction in terms of peripheral defocus, as well as to get the clear vision from the mid periphery. Now, the third type of lens available, that is the Nova lens, from that progressive addition lens in the horizontal meridian. So in the center part, that is for the clear vision for the central area. But in a horizontal manner, there is a progressive addition lens. So we can get the peripheral defocusing even in the periphery while looking at through the mid periphery of that glasses. Now the fourth one, that is come with the Zeiss MyoCare lens. Now Zeiss MyoCare lens is based on basically two technology. That one is the orthokerato. So what happens in orthokerato lens? Like when we wear the orthokerato lens, the central part becomes flat, so that the central rays focus exactly on the retina. But the mid periphery part of the cornea becomes little steep, and because of that, from the steepening, the peripheral rays also focus in front of the retina, not behind the retina. So that will also give the peripheral defocusing theory. Along with that, it is a combination of soft multifocal contact lens. So the Zeiss Myocare is a combination of, we can say, the soft multifocal lens as well as the orthokeratosis lens. Here you can see there is some rings available on the glasses, which would be a combination of ortho-K as well as the multifocal contact lens. Now the Zeiss Myocare is based on basically two techniques. One is the CARE technology, that is a cylindrical annular refractive elements in the front surface of the glasses in a ring manner. And on the back surface, the back pillar, we can say, it is a clear focus design, which is helpful so that when the child is looking from the any angle of the glasses, the back surface of the lens will give the clear vision. So that is the advantage of the Zeiss Myocare lens, that this has a the front surface, the front pillar, that is for the CARE technology for the peripheral defocusing, while the back pillar, that is a back surface optimization, we can say, that is a clear focus design that will help to look from any angle of that glasses and have a clear vision in any angle. So the CARE technology and the defocusing of the back surface, that is a clear focus design, help us the child look from any angle will get a clear vision. Sorry. Now the CARE geometry is based on the vivid, like we can say that the EDOF intraocular lens. It will give a forms a caustic, that means it will distribute the rays in a which manner that we can get the depth of focus. So what we get in the EDOF lens, like VVT from the alcohol, any intraocular lens which has a EDOF technology, the same technology applied in the CARE geometry. So we can get the better depth of focus, and at the same time we can get the better vision in all gaze angles. So this was about the Zeiss Myocare. Now Zeiss Myocare available in two forms, the softer version and the normal version. The normal version is, like we can say, the harder one. It has a central clear zone of 9 millimeter and the power is addition of 4.6. Like the softer version for the low myopia, that is a clear zone of 7 millimeter and the surface power is around plus 3.8. So this was regarding the different type of spectacle lens available for the progressive myopia. We are not touching the contact lens as well as the progressive lens for the accommodative lens. Thank you.
Thank you, Dr. Kalpit. I think a comparative evaluation will be interesting. And what about the costs? Which ones are cheaper? Which ones are more expensive? Any idea about, because we are a poor country,
yeah,
we also need to look
cost,
at
cost is like this multinational company, that MioSmart as well as that Siles, that cost around 11 to 12,000. But the Indian companies have also started making this type of glasses. Even we can get some local manufacturer from, they are importing from the China also. So in that case, we can get around 5 to 6,000. The second thing, that multinational company are also like providing a facility that if the glasses power increase more than 0.5 within 6 months, they can also replace the new glasses at without any charging extra one.
Can I ask a question, please?
How often they need to be changed? I think every year you need to change them because the reflection may change at the same time. So I think a cost of about 10,000 per year, approximately.
Yes. So if
that way,
there is not much of change, and of course, that if the scratches and everything would be there, so the scratching and everything, then it would be need to replace with that same charge.
True. So atropine that way is much cheaper in our setting.
Dr. Kalpit, you have an experience with the newer Zeiss lens. I think the cost of it is comparatively less. So I mean,
yes, Zeiss, but the problem. Yeah, the problem with the Zeiss, then that cost around 4 to 5,000, but it is less than -4 diopter only. Okay. If more than -4, then it requires the same charges around 8 to 9,000 rupees.
And there's some peripheral vision is also affected, I think. In good number of these cases, mid-peripheral vision is not as good as because of this defocus. So there are some issues also with that. Dr. Kalpit?
Yeah, please, sir.
I'm saying the mid-peripheral vision may also be subnormal because of this myopic defocus. So that may be another
Yes.
disadvantage.
No. Sir, for that only, that different glasses technology is available, that the Zeiss MyoCare, that back surface optimization, that is a specific technology that is called the clear focus design. So while looking at the periphery also, there would be no blurring of the vision. Like Hoya MioSmart and the Stilex, that is from the Essilor, they have children, intelligent children can complain that while looking from the mid periphery, they have a little bit blurring of the vision. Or we can say same thing like when we start with the progressive lens, that in the mid periphery there is a little blurring or the curvature of the image, but this will not happen with that Zeiss MioCare.
Yeah, but
Very
I think
informative.
Are there any adjustment difficulties with these spectacles, or do the children easily accept the glasses? Dr.
Yeah, initial period, there is a time, I always say to that children that almost around 1 week to 10 days will require for the adjustment. Even for, like I would say, for my daughter is also using the same one. And when she is like in the classroom, something happens when she is looking from little bit of periphery. But now, like same with the progressive lens, she has been acquainted.
Can you stop sharing your screen so that...
Yeah, Dr. Kalpit, thank you.
Yeah.
And I think, shall we move on to the last talk?
Question, sir? Can I ask one question to Dr. Kalpit? I just wanted to know that if he has tried any time this my side contact lenses from Cooper Vision, which they are claiming that it's only FDA approval and 52% myopia progression retardation along with any atropine. So have you tried this, and what is the cost of that?
No, I have not used the contact lens.
Okay.
I think with that, we move on to the last talk of this session. That will be by Dr. Rishikesh Mai, and he'll be talking on role of lifestyle modifications in myopia. Dr. Rishikesh doesn't need any introduction. He's a very hardworking, sincere member of our SPOCI, and he's always ready for doing whatever he's told. He always is very happy doing it, and we are really, very happy with him. And he's working at as a director of Dost Netralaya Nagpur, executive committee member, SPOCI, recipient of many awards like Best Poster Podium Presentation, AIOC, a Cohen Oration Award for work in pediatric ophthalmology. Dr. Rishikesh, please.
Thank you, SPOCI. Thank you, sir. And I will be sharing my presentation. I would also like to thank NTOD for this wonderful session on guidelines for myopia control. My slide, my presentation is visible?
Yes, sir. It's visible. Just make it the full screen.
Make it a full screen.
Okay, now,
yes.
Yeah.
Right, sir.
Okay, so I think most of the topics in myopia control have been covered. So I won't be going into the topics which have been covered, but try to share something which has not been covered so far. So I'll be discussing on lifestyle modifications which are recommended for control of myopia. First of all, we need to know why there should be control of myopia progression. The most important is that high myopia is associated with certain ophthalmic complications, many of which are blinding conditions like retinal detachment, macular degeneration, and myopia related glaucoma. Also, a child with high myopia is highly dependent on glasses, which makes him unable to perform everyday tasks without glasses and makes him visually handicapped. Also, it adds to the financial burden. Not only is the frequent changes of glasses and contact lenses, but if surgical interventions are needed for complications associated with myopia, and also a psychological impact. That is, a high index child wearing a high index glass will probably have a different psychological feeling looking at children with normal glasses or children without glasses. So he might have something like low self-esteem, and his quality of vision might be compromised. Quality of life might be compromised. There are various myopia control measures which have been discussed, and in this particular session, like glasses, contact lenses, surgical interventions which are anecdotal, which nobody is following right now, orthokeratology, lifestyle modifications, which I will be covering, diluted atropine, which has been extensively covered, and also DIMS. Dr. Kalbir has covered that very well. So few of these interventions have been found not to be working, like multifocal glasses or routine contact lenses or surgical interventions. What probably works or may work, but not in all cases, is lifestyle modification and orthokeratology. What has been found with multiple randomized clinical trial is that low-dose atropine and DIMS glasses definitely work in almost all routine cases of myopia for control of progression. So I will be discussing the lifestyle modifications, which include mostly outdoor activities. Outdoor activities, they help in preventing the onset of myopia, but not prevent the progression of myopia, as multiple studies have found. They also reduce the reducing the near work, especially screen activities, has been recommended, and adequate room illumination. I'll be covering this part shortly. And Dr. Siddharth has covered about nutritional supplements, especially carbohydrate use, which I was not aware of, but most of the studies otherwise have said that routine, nutritional supplements like vitamin C, vitamin D, they do not help in controlling the myopia progression. Lifestyle modification has certain advantages, like it helps in not only controlling of onset of myopia, but also overall healthy lifestyle. It prevents the onset of myopia, and also it is cheap. Disadvantages are that with digital devices all around, I mean, for children to follow a lifestyle without digital devices is not easy in the long term. Also, it helps in only arresting the onset of myopia, not the progression, and it alone may not work. So you might have to supplement with other myopia control strategies like low-dose atropine or DIMS glasses. So the risk factors for myopia onset in children are, as per the various studies, parental myopia, as everybody is aware of. Also, studies abroad and also North India myopia control study has found that females are more prone to develop myopia compared to males, especially more than 9 years. Preterm infants, but that doesn't count as actual myopia, but they are predisposed. Children with more BMI, I think Siddharth has covered this point very well. Children with more BMI are likely to have myopia onset. And also it has been found by studies that cognitive functions and education, I mean, if children are more exposed to academic activities, they are likely to develop myopia compared to the children who are more with nature. So environmental factors like, time spent outdoors is very important part, and it has been recommended that at least 1 hour per day should be spent outdoors for all children. Also, there has been a study by Macron et al. They have found that if there is a white background on a white text on a black background, it helps in choroidal thickening and prevents axial elongation compared to black text on.
We can't hear you, Dr. Rishikesh.
Yes, I'm calling him.
We can't hear, na?
We cannot hear. I'm just giving him a call.
Maybe facing a low network.
Yeah. There is a problem with presentation, I think.
I think the connection has somehow.
Yeah, something is there.
Yeah, he's not picking up phone. Dr. Shubhangi, you also may try. I'm trying, but he's not picking up phone.
I'm trying.
I called him. He's not.
He's not picking up the phone. Yes.
I think he knows something has gone wrong, so he must be trying
Yes.
from his side.
Yeah, from the same phone he may be trying.
So if Pandey sir, if you can
He's out
run
of,
some panel
I think he's
discussion
out
till
of
then.
Nagpur, and he's presenting from there. Probably he's out of Nagpur. Got a call. हॅलो, हा ऋषी, ऐकू नाही येत आहे, काय झालं? He said there's some problem with the Zoom. He's reconnecting in a minute.
Okay, then we'll wait.
Yes.
It was going so smoothly.
So
Can I ask a question in between?
Yeah, I think we can go ahead with the discussion.
The point, see, two of my patients, those who are on mitro, they have said that they are finding it difficult. Both of them are one is in the 9th and another one is in the 10th standard. But still, their myopia is still in progress, and they have said that reading becomes difficult even on the next day afternoon also. So, does anyone have any experience of this?
I have no experience of any blurred vision with whatever patients I've put on, but there have been reports that even with 0.01% of atropine, there are atropine is found in the aqueous and vitreous. So it could affect some individuals.
Very clinically insignificant.
Have been a report.
It's very insignificant. Yes.
With 0.01 atropine. It's difficult.
Maybe
it's very less likely.
Maybe child is not happy using the drops. So he says
no, it is. He is very obedient child. He is a very obedient child. And
I had an experience with one child who was pediatrician's child. So luckily he was aware, it was present in the clinic, but he had all the complaints of dry mouth and everything. So the pediatrician himself took care, but that's only one child. So it's very, very rare.
Yeah.
Even I had 1 out of 300 only who complained of photophobia. I think she was a 13-year-old girl. She was more into the internet, and I think she must have gone through the atropine study. She did not stop though. She said, "I'm okay."
Yeah.
Now I am okay. So
patients have to be committed also to the treatment, and that's also important. I think they have to be told that this is important and it's going to help you. If you tell them casually to put the drops, they won't put, I think. So that commitment and understanding from the patient side is
some other factors also there, and they attribute it to drops.
Yes. And it is said that when you are using for very high concentration, like 1%, you should look for the PDA. Otherwise, it doesn't.
The 1% is definitely going to have issues, but 0.01, I think, very unlikely.
I never had a blurring of vision, but
I think Dr. Rishi's screen is visible. Can we?
I'm really sorry for this, actually.
Yeah, he's back.
Yeah. So can I continue with?
Yeah, please go ahead.
I'm sorry, thank you. So I'll go with the optimization of the environmental factors. Just 3-4 slides actually. As per the recommendation, the outdoor activity should be at least 1 hour of outdoor activity in sun and fresh air. Also restricting the outdoor activity. They have quantified it by one study where they have found that restricting the outdoor activity by 1 hour per week can increase the chances of myopia by 2%. They have also quantified the indoor lighting which should be used for near activity, which should be around 100 to 500 lux of LED illumination, low emission diode emission. And the near activity in bright illumination is what is recommended instead of dim light, even for screen related activities. Coming to the behavioral changes which have been suggested, the outdoor activities I just mentioned, also LED instead of any other way of lighting. The adequate distance is around 35 to 50 centimeters, adequate posture, and avoiding head tilt. In fact, there has been a study where they have found that near activity or writing with the head tilt is more likely to increase myopia compared to maintaining an erect posture. Frequent breaks of 40 as 4. As you can see, even on the Zoom, meetings, it is only for 40 minutes because they have found that not only the attention span, but the chances of myopia progression are more if near activities are continued for longer. So there should be a break of 4 minutes after every 40 minutes of activity. And nutritional supplements have not been found to have any role. During the pandemic, we conducted a study for myopia progression, comparing the myopia progression of same set of children in the pre-pandemic versus the pandemic, and we found the following results. We studied around 58 children. The data was presented at WSPS last year. Out of which 32 were male and 26 were female. We found that some of the data, though it was not statistically significant, but the rate of progression of myopia was definitely there during the pandemic, when children were more exposed to digital devices compared to the pre-pandemic period. And this rate of increase was more in age group 11 to 15 years, and also for females compared to males. In these two groups, the data was statistically significant. But overall, there was increasing trend of myopia progression during the pandemic period compared to the pre-pandemic, and also for age group 11 to 15 years and for females compared to males. Though diluted atropine group was smaller, we found that the diluted atropine also, if they were exposed to digital devices, that there were chances of myopia progression in those cases also. That means that just using diluted atropine or DIMS, perhaps DIMS we did not study, but for extended use of digital devices, they may show progression. So lifestyle modification is important even for those cases also. So I'd like to conclude by saying that there is definite role of lifestyle modification in control of myopia. It has to be advised for all children, especially for children with high risk. High risk children, which I mentioned in this presentation. Also, myopia is not only a disease of the eye, it is a lifestyle disease, just like having a progression of myopia or onset of myopia is something like cardiovascular disease, which is also a lifestyle disease. And it has to be complemented. The lifestyle modification has to be complemented with other myopia control strategies like diluted atropine and DIMS glasses. Thank you.
Thank you, Dr. Rishikesh. I think there's one proposition that probably in dark, longer wavelengths are left and shorter wavelengths are sort of eliminated. So more red light will have less refraction, so it tends to get focused behind. So that probably is one of the reasons. Nobody knows. I think this will need long-term studies to see. So light is a very important aspect. And as you go in ocean, as you go down and down, less and less light. So more and more divergent rays. So that is also another factor, I think, which contributes, because they need more power to focus. So as you go down in water, so because we all came from ocean, so I think ocean is the backdrop of what we are facing. Thank you.
I would like to express my apologies for the delay, and thank you for the patience.
No, that was not your fault, I think, and we did discuss some points in between. So now it's open to discussion with the panelists. And I think most of things have been discussed in great detail. Anybody would like to say something? Dr. Love? Dr. Love and Dr. Love has not spoken. Dr. Love? Is he there? And Dr. Niluparna Deori? I think both are not there. Dr. Madhav? So I think we are Dr. Parikshit, Dr. Subhash, and Dr. Shreya. We are 3-4 people are here. So what we need to, anybody would like to say
something? Can we initiate with the introduction in the short bit?
Hello, Rishikesh, what were you saying?
Dr. Pandey.
Yeah.
Let me express my special thanks to our co-opted member, Dr. Subhash. He is instrumental in starting this project. Since beginning, he was after that. And he has insisted me and yourself also. We must give a special thanks to him, Dr. Subhash Dedia.
Yeah.
And he is all the time present in all the talks and everywhere. Thank you.
So now it's open to discussion. We are thankful to you also, because you initiated this whole exercise with entire people, and we have managed to do it within 1.5 years' time, because it started before Chandigarh conference, and we have done it in less than 1 year's time. And this has been a lot of effort on part of the entire and you and the entire SPOCI team. We are all thankful to all of them, and it's a public health issue. So we all need to work together, and now we need to distribute these hard copies to all the practicing doctors, means ophthalmologists, and also maybe pediatricians, and some school teachers and parents in whatever way we can, so that this gets wider publicity and people are made aware, so that they can do some preventive aspect. I think is very important in myopia. So if you are able to do that, that will also be a great effort. Of course, therapeutic aspects are there, but prevention is very, I think, central to this problem. So I think I request and taught people to have a very good distribution network, distribute these copies to all ophthalmologists they have on their panel, and even to pediatricians. And then I think it will make an impact, and that's how probably we'll be able to tackle it.
Yeah,
We are really
we
grateful
will
to
be
Dr.
thankful to, hello,
Yeah.
we will be thankful to Mr. Markey. Since beginning, he was all the time calling every time, sir, what we should do, where we should do, what to do. He is the person who has really persuaded us for a noble cause. I'm very much thankful to him and the entire directors and executive directors of entire team also. And the great thing, our secretary is the ultimate person who has done a lot of editing, lot of work continuously till today. He's taking charge of all the online, offline conferences. And thank you very much. Thank you all SOSI members. Thank you.
Thank you, Dr. P.K. Pandey sir, Dr. Deshpande sir, and all colleague and panelists, and special thanks to Mr. Raman, Mr. Rahul, and Mr. Ibrahim. We really learned a lot from all this webinar. I'm so grateful to all of you. Thank you so much.
Hats off to all of
I
you.
would like to thank
everyone. Thanks everyone for the for including me into this talk, and had a good discussion on all the points. Thanks a lot.
Excellent talks by all the speakers, and thank you everyone for including me in this. I think Dr. Mai practiced what he preached. He gave us a break in 40 things, and it
Actually,
was
I'm not
really
very. I
needed.
mean, the link between her and me is not very good. Actually, most of the time it happens.
No, but we needed the break, as clearly mentioned by you. So just one more suggestion, Pandey sir, you said that among the teachers and all, I think it would be only better if we give these guidelines to the medicos, because like Shubhangi ma'am has rightly pointed out, they shouldn't start giving this over-the-counter drug should not be available. So just that I wanted to mention. Thank you again, everyone.
Just to create awareness, I think. Therapeutic part we may not talk. We may just talk of outdoor activities, and near work part I think needs to be stressed to them, that if they do near work at bigger distance, that may be helpful. I think that part I think needs to be stressed as
some may not be aware that some such drug is also available for myopia progression. So some more such seminars with the inclusion of pediatricians.
That is very important.
The importance of myopia control or progression would be
because pediatricians see these children regularly. I think they go to them for their milestones and everything. So if they can send them over to us, they will all get reflected at least. And that is the basic minimum thing to start with.
Absolutely.
Hello, Shubhangi.
Yes, sir.
I'm sure that you are quite efficient to continue the same project throughout your presidential year next year now. Be ready for that. Continue this project. And I'm sure you are quite able for that. Your team and entire Rishikesh and all our SPOSI members will definitely help you to take this project further ahead in collaboration with anybody. Thank you very much.
And I'm very thankful to Aurangabad team and Dr. Deshpande ji and the entire Maharashtra part who did that conference so well, and that was a great input for this guideline. For these guidelines also, I think that was the major cornerstone what we did in Aurangabad.
That all credit goes to Vaishali Une.
Yeah.
No, sir.
Organizing secretary of Aurangabad this midterm conference. Great work she has done.
Sir. It was
all
team
the day
effort.
and night she was working. Great job she has done. All credit goes to Vaishali. Thank you.
That was the best midterm conference we had, I think. And that credit goes to all of you, and especially to Dr. Vaishali.
Thank you, sir.
It was very wonderful. Please do come over to Rishikesh. We would like to felicitate you. And I should thank
suggest
Mr.
Dr.
Alpesh
Pandey.
also. He has been very helpful all through. Mr. Alpesh Chauhan from Entod. He has always been very helpful and always forthright and always willing to do whatever he has been very this thing.
It was nice discussion. Dr. Pandey, I would suggest that by the next SPOSI conference, if you can make a guideline of electronic gadget use to be uniformly considered for children, school-going children, it will be nice.
Yeah,
that's a good idea.
Environmental
That's a good
modifications.
idea.
We can
And
work
That
upon
will help.
And we can launch an annual
One.
policy. Yes.
refractive correction in children, and this part I think needs to be addressed because these are areas which do need little
Right.
this thing attention. So
thank you.
Thank you.
Mr. Raman.
Yeah, so just I will like to just
Yeah.
quickly show the guideline, both the copies. These are like the soft as well as the hard copy is available now. Soft copy is available on both the portals for the SPOSI web portal as well as the Entod web portals. This is the cover page of the guidelines, the childhood myopia in association with the SPOSI and in collaboration with the Entod Pharmaceutical consensus guideline on prevention of management. This will be ad of our products that Mitro. This is the we are making it. This is index message from the president, that is the Deshpande sir. Message from the secretary, that is from the Pandey sir. These are all the committee members of the SPOSI. We have incorporated those who has contributed on the online as well as the offline for these guideline formations. This is the acknowledgement for all the 40 doctors, those who has contributed the content into it. This will be entire content is available now for the utilizations. In the conferences also, we are planning to have distributions of it. So this is the entire the glimpse of the photograph where we have conducted the 2 meetings, and this will be the last page. It will be available on both the ways, sir. Soft copy as well as the hard copy. It is available.
Thank you.
And this is on website also. It is available on our website also. And
yes, sir.
we
Yes,
have
sir.
to, yeah, and we have to keep in mind that these are guidelines. They are not to be taken as level 1 evidence coming from RCT. So these are likely to change. So we have to keep that in mind. So nobody can take us to court and put us in. I mean, just precaution. We must, I think, verify that. I think we have mentioned it at the end of the guidelines that these are only advisories. These are not sort of based on level 1 evidence.
And we also seek Entod's help for next year, continuing this myopia progression, any work we do with this.
Yeah, definitely. I think
so here
they are going to start 0.5 atropine also.
Yes.
0.5
That's what we are waiting for.
So we have to compare, we have to do all the things, and they will be more interested in comparing everything.
So are they coming with 0.025 or 0.5, 0.05? Mr. Raman?
0.05.
0.05.
0.05, sir.
0.05.
Yes.
Yes,
That will
0.05.
be, I think, a good.
That was what
0.05.
studied. Compare 0.01 and 0.05.
0.05.
Yeah. 0.05 they say is better. So anyway, time will prove what is better and what is not better. So I think with that, I thank everyone. We close this session. Anything anybody would like to say? Otherwise,
so we have attendance of some around 2,171, sir.
That's
Our
excellent.
team also they were there.
Massive.
So thanks to all
very
attendees.
good.
Wonderful.
Yeah, so I think that will help us spread this message that we need to tackle myopia right on, and otherwise it's going to really eat us up with passage of time. So we all have to act jointly and together we'll be able to overcome it. So with that, shall we close this webinar?
Yes, sir. Yes, sir. Rahul, we can end for the meeting.
Thank you, everybody. Thank you.
Thank you.
Thank you, sir.
Thank
See
you,
you at
everybody.
Thank you, sir. Thank you so much, sir.
Thank you.
Thanks a
Being with
lot.
everyone.
Bye, Dr.
Really
Shubhangi,
All you
Dr.
should
Siddharth,
attend
Dr.
the
Savli,
conference now.
Dr. Vaishali.
All you
Thank
should
you.
attend all
Thank
India
you. Thank you
conference.
so much.
And please come to Rishikesh. Rishikesh is calling you, land of Devnagari. Please do come over, all of you. Everybody is
Yeah,
requested.
we all are waiting
Please,
to come, sir.
please
It's
do.
very
Please
nice,
do. And
beautiful
tell your
place.
friends also to come. It will
Yeah.
be nice being there in
Thank
December.
you.
Yeah.
Thank you, sir.
Thank you.
Thank you,
Thank you, all
everyone.
of you.
Thank you.
Bye-bye.
Bye.
Thank you. Bye.
Bye.